What if your hospital got shut down by a cyber attack, stopping all ability to dispense medications, render care, or treat any patients? How about if it's run on technology from before the iPhone, and the funding to upgrade it to modern technology just vanished? What happens when the Wi-Fi won't reach the emergency room, or your nurses are forced to return to charting on paper records, but they're from an age group that has never ever done so before, and there's no processes in place to even get that done anymore? The problem is this isn't made up. This is reality right here, right now in 2025, rural America. Join us as we show you what's happening right now in America's critical rural hospitals. This is Cybercrime Junkies, and now the show. Catch us on YouTube, follow us on LinkedIn, and dive deeper at cybercrimejunkies.com. Don't just watch, be the type of person that fights back. This is Cybercrime Junkies, and now the show. All right, well, welcome everybody to Cybercrime Junkies. I am your host, David Mauro. In the studio today is a friend of the podcast and somebody we have a lot of respect for. They are in the trenches of rural America, in healthcare, in IT, and they've exhibited great leadership over the years and driven a lot of really positive initiatives helping improve patient health and care. And I cannot wait to have the interview. Shawn, it is Shawn Weldin, a director of IT at Sabetha Community Hospital in Kansas. Shawn, welcome to the studio, my friend.
Thanks, Dave.
Well, what has been happening in rural healthcare America lately?
A lot of things just kind of moving along as everywhere, with everything going on with the USDA funding, with kind of thing going on the Fed level, everything is just changing. Nobody knows what's next is always kind of the problem with the big shake on the Fed level. A lot of our funding, people don't realize on the small hospitals, definitely our funding comes from Department of Ag. Any of those loans we get, the big loans we get from the government for building projects, those big things come from the USDA, which seems like a really interesting spot for healthcare. But I guess somebody had to have it, and it was as good a spot as any for agriculture and rural communities. Made a lot of sense.
So back up a second. So are you telling me, so the USDA, which I think of like the stamp on steaks, right? They're actually the ones that fund a lot of your building development for rural
small rural hospitals. Yeah, that's the approval entity for our
really
our loans for like a new building. So you're a hospital loan.
Yeah, a lot of people may know that. I didn't know that.
Yeah,
so
it's an interesting kind of
holy cow
relationship.
So when they cut that, what type of cuts have happened?
So we've been trying to build a hospital. The building I'm sitting in, as you can kind of tell, as my office is, this building was built in 1910.
1910, back when I was a kid.
Yeah, so back in the good old days.
Yes, back in the good old days.
When this structure I was in, this used to be a waiting room for patients. My office used to be a waiting room. So this area I'm in, right, is built in 1910. And then the newer half of this addition was built in 1930.
Oh, wow. So the more modern is from pre-World War II.
Yes, we jumped a couple wars there. It was nice.
Holy cow.
And then we built a big addition on in 2003. So we have but it's 20 years old now. So as we're kind of looking at that, we've not spent a whole lot of money on our infrastructure. Since that 2003 addition, it's amazing how much stuff it's changed. Think about technology in 2003. This building, running network cables and phone wiring through this is a nightmare. It was pre-iPhone too, so it probably has the state. When you see homes that are older, they always have the stations for the computers. When in reality, everybody's working on computers everywhere. In that new building, we ended up mounting computers in rooms that really were not made for it. We're just kind of tight on space. We've done a great job, and we've done a great job maintaining what we got. But it's this building, the floors are a foot thick concrete, but interlaced steel.
Yeah, do you have cinder block walls too? Or
we don't. They're plaster.
Plaster. Oh,
They're
wow.
plaster. The exterior here is brick. So we've got trying to run network cables through these floors and the Wi-Fi through this steel interlaced flooring is just kind of a challenge.
Well, I know with some older schools and some older construction sites, when they have the cinder block walls, it really messes with the radio frequency. So Wi-Fi can't go where it needs to go.
Yeah, it's a challenge. Just kind of
So you
maintaining.
got to run cable, you got to run Ethernet, power over Ethernet, etc. You've got to run those hot lines all over the place.
Yeah, and we've got some closets kind of sprinkled here and there because it's easier to run every floor closet to floor instead of going through this big, huge, thick floor everywhere. So that's not ideal. Same for that. We'd love to run some fiber around here, but if we're going to build, there's no reason to hopefully spend the money on fiber we're going to rip out. So we're trying to kind of maintain as we can, but we're hitting the wall on a couple of things where we need to decide. And we've been waiting for the USDA for quite a while, and we've had some motion here recently. There's been some changes on the level, Fed level now here recently that we're seeing some improvements. So we're hopeful. Our state senators, everybody's been really pushing hard for us.
Yeah, I've been reading about it because I keep up with things in Kansas a lot. And from what I understand is in the beginning, there was a sense by the administration that there was just money bleeding everywhere. And so they just kind of stopped everything. And now they're kind of releasing certain things after they verify, hey, this isn't what they deem as waste. They're looking like if it's coming to rural healthcare, they see the need, and they're loosening.
I know the folks at the USDA are doing their kind of diligence. We're not blaming them for wanting to make sure that money's being sent properly, which it should be. Right. It's just we're 3 years into this almost. We're trying to get this kind of approved. We thought we were hopeful to have this done 3 years ago. So it's just been a process of submitting questions, and it takes time. Submit a question, got to go through the right people, and then at one point with the buyouts and stuff, everybody left. So we're starting over with new people and new staff that just don't know our story, and so we got to kind of start over from scratch. Some of them that's gotten better here. We've had some good motion in the last month on that, so fingers crossed we'll have some positive news here shortly, hopefully.
Well, that's great. And the plan is to expand. Like you have a new set of land and new plans. So or are you going to expand on the existing?
Expand the existing campus. We've purchased some land. The city had a shop building south of us that we've kind of taken over. So we have that land now. We bought 2 years ago, thinking we'd have it, tearing ground up by now.
Right.
So we've had that. This older structure, we love it, but it's just not a hospital anymore. It's a cool building. It's just I've got HVAC. We have window air conditioners everywhere. It's steam heat. It's just not a hospital anymore.
Yep.
So we'll keep the 2003 structure and remodel a lot of it. It's going to get a big remodel as part of this, hopefully, and then add a huge new. We have a clinic downtown that's off site. Bring them on site and all one kind of campus setup. So that's the plan.
Yeah, unbelievable. So when we think about 2003, when that newest wing or the newest portion of the building was built, things were a lot different then. And when I look at especially healthcare, because it comes up in all verticals, but in particular healthcare, we used to have two versions of our world. Like we had computers, right? We had them back in 2003. We had them in 2010. This is Cybercrime Junkies. And now the show. But we still had, and correct me if I'm wrong, but you live it every day, like we still had processes. We still had kinetic, physical processes, paper. There was still a way, and it wasn't even just having things in paper versus scanning it and having it digital. It was the processes and the protocols and the ways of doing things. And you were able to do all these things. And should the computers break down, whatever it was, whether it was a cyber attack, it was more rare then, but it was, internet outage or whatever, you didn't have the type of impact that you do in the last 5 years. Like we are so dependent on our technology, especially in healthcare. It seems remarkable because we're able to do so many advanced things now because of that, but yet we're more dependent. And when things like cyber attacks happen, we're more devastated because having to go back to pen and paper sounds easy, but it's not, because nobody's done it.
It used to be.
Like, yeah, nobody has done it. Like, the people that are there now are either younger and they have no experience in the actual kinetic world and paper processes, but the processes aren't there. Like, the actual way of doing it, right?
Go back to some of that, because when we went live with our first health record, and the clinic went live in 2007 or 2006 with our first ambulatory record, which most people did the clinic first. We went live full EHR at the hospital in about 2012. And when the system went down, the nurse was like, "Yay, paper!" And they pull paper out, and they'd be just hopping on it, and it was great. And then we've had that shift now. We had nurses that left the nursing areas because they didn't want to do charting. I don't do electronic charting. I'm going to go to a different area of nursing. Even internally at that point, like, I'm going to go to a different part of the hospital that doesn't do electronic charting. Of course, now everybody does it.
Why is that? Is it too burdensome? Is it too much detail?
Some of them were people that just weren't computer savvy, didn't feel comfortable with it. And so they said, "I'm going to go up here where I don't have to." And then, of course, it followed them. 2 years later, they had to. But some of these nurses, the new nurses we have are great, but they've never paper charted. They never had to. They, even from school all the way through everything they've ever had. They're young enough now that they've never. Most of them, some didn't have school books at the end of their careers.
Right. Exactly.
Everything was online.
They don't know how to write in cursive.
They don't. They don't. And dealing with some of that, here, I'm going to give you this stack of papers to chart on. And before, the old nurses just, "Oh yeah, let's get this done. I can make a nurse's note in a moment. Watch this." And now they're like, "I will wait and write on this napkin until the computer's back up." And then until we finally have to say, "Hey, it's a shift change. You're going to go home. You've got to document something on paper."
Right.
And then we'll scan it in, which they don't want to document stuff on paper. Then they're going to put it back in the computer. We've kind of said, "Hey, we'll scan stuff in now." But it's just a shift change from the last 20 years, where we've definitely seen, even the last 10 years, where we've seen the migration to staff that are very, very computer oriented and very computer savvy, which is great.
Mm-hmm.
We're not explaining how to get in your email, how to get into how to do things. Multi-factor is not the big factor to this younger generation, because it's not. They've been doing it. They've been dealing
with multi-factor,
and they should. We train our staff that, hey, if your bank's not using multi-factor,
get a different bank. Yeah, get a different bank.
This is no longer a best practice. It is standard operating at this point.
I mean, and the way we think about it, there's security on one end, and then there's convenience on the other. And if you're too convenient, you're gonna get ruined. Right, and if you're too secure, then it interrupts with operations.
Well, then that's
so
when people
really
try
just having that balance, finding that balance, and most of the younger generation has grown up with that balance. They've had it through video games and social media, etc., and school.
We always had a problem with this. If it makes stuff too secure, it's unusable. That's when we'll find ways around it, and that's where you security breaches. People like, "Oh, I didn't want to use this thing that made me sign in 5 different ways. I'm gonna just put it in my personal stuff, and I'll just use my home email to send stuff, because I don't want to mess with my work email. It's too complicated." So it's that fine line of trying to find that balance where it's secure as it can be, but usable enough that staff can deal with. The end of the day, we're still dealing with people that need to do their jobs, and the same for us. We're very cyber aware as IT people, but having that other side where say, "Hey, yeah, I can't lock this down so much that's unusable." It's like not having it.
Well, I always think you don't have to, right? Like, in an ideal world, it would be great to have everything locked down, and then there's but it becomes unfunctional, and it almost becomes cost prohibitive, right?
Yeah, because we're buying this, we're not even using it at this point, because we've got to make it so secure that the staff are finding workarounds, or they're just refusing to use the systems that we have that say, "It's too complicated, I'm just not going to use it." So we're wasting money on it because it's not being used anyway.
Right. But the key to me, is just doing enough so that the attackers move on past you. You know what I mean? There's
you don't want to be the low-hanging fruit there.
Yeah, like, I always view it as we're at the beach, and there's people from our organization, people from other organizations, people from our family, other families there, and we see fins in the water, right? It could be a shark, it could be a dolphin. I'm not freaking sticking around to find out. I'm going to start swimming to shore. And the truth is, we'll never swim fast enough to outswim that shark. But the reality is, we don't have to. We just have to do enough to beat that guy. Like, we just have to beat the organizations that aren't doing fundamental things, because they're really, the attackers' mentality is really just low-hanging fruit, right? They're just going after whatever they can get. They're not necessarily going after your organization or your people individually. They're really just going after the vulnerabilities. Who's got an open door? Who's got an open port? Where can we find those vulnerabilities?
Yeah, it's just trying to do the best you can. We all have, especially in the rural world, staffing's an issue.
Resource.
I'm very lucky in a town where
Yep.
I'm from, where we have several IT people that live here in this small town, but resources and doing more with less. All these cybersecurity stuff, my department doesn't make any money. I'm not a profit generating department, but I can spend money like a crazy person if I have to. We can spend a lot of money really fast.
I will say I've been working with organizations on measuring risk, though, and there is return on mitigation.
100%.
So, when you invest in a new device or a new technology, that's more because it's cool, it's fun, it's convenient, right? And there might not be as good of a return, but when you're investing in security controls, there is actually a return, because it's not only operating and you're getting the benefit of it, but it's reducing risk. And so if it lowers the amount of cost, should there be an event, or it lowers the risk of an event ever happen, that is actually a really measurable metric that can be seen on a P&L, because that money doesn't go out. It's not return on investment, because it doesn't generate new revenue, but it lowers the amount of revenue that has to go out, and that still has a positive impact on P&L.
And
which
a lot
is great.
of IT, hearing the IT guys in Kansas a lot is we just don't have any money. We don't have any money. We don't have any funding.
Right.
Which I'm there. We're all there. We're all, there's a stat out there somewhere that the percentage of hospitals in Kansas that are on financial downturns right now is majority of us.
Right.
We don't
Absolutely.
make money. We're all nonprofits anyway, but we're not making any money, definitely. And just a lot of that is, I'm very lucky to have some administration that understands, that technology is not going anywhere. Security stuff is only going to get more. Our antivirus costs, for a long time, were, as part of a larger health group, we can purchase those kind of together, and get some better volume. But we went from, they more than quadrupled in 1 year, because we went from having just traditional AV to having, MDR, XDR,
right?
And it was one of those things where it's like, this has worked for 10 years, and it's worked, as far as I know, it's worked just fine. We've not had any complaints with it.
It's been quite effective, actually.
Either it's doing a great job, or it's doing nothing, because we're not getting much stuff out of it. Either it's doing great, where it's just taking care of it and we're not seeing any issues, or it's letting everything through and we just can't tell. So when we move to the XDR and the MDR, it's like, this is a different animal, and the cost is so much more. And I'm very lucky to have administration and some folks to say, this is not just the latest greatest fad. This is becoming, or will very soon become, a requirement for insurance. We have to have some kind of next gen. So either we can wait till we have to have it, and every day we don't have it, we now know we need it at this point. We're higher risk. So did I go out that day and check that day? No, I put it in the budget. We talked through it. It became, within the next year, we had worked through it. We're adding more features to it now on next budget cycle. Process of working with your administration a lot is just saying, hey, I know I'm not making us any money here, but one breach, one cyber attack pays for itself. This stuff all pays for itself for forever. If we ever have
exactly
if it does this job once, it's paid for itself. So,
yeah. I mean, the breach costs for rural healthcare have gone up exponentially in the last 4 years. I mean, it's a lot. So anytime you can reduce that risk or lower the impact, etc., there is a huge benefit, and to the providers too, and to the actual patients. So, rural healthcare, when we were talking about the greater impact, when you think about when rural healthcare gets hit, it could be the only level tier hospital at that level for that patient in a hour travel or a 2 hour travel.
In Kansas, easily. There's several hospitals. There's several counties. Kansas don't have hospital at all.
Right. Exactly. And so you have to, if they're down because of a ransomware attack or whatever, then you've got to literally, when every minute counts, you've got to ship that patient over to another.
And it's also like for a stroke. So, there's time frames of success for a stroke that having that image sent off and be read by a radiologist within so many minutes is very critical for a patient's care to know what to give them for anti-clotting and that kind of stuff. And if we're having an internet issue, we're having a cyber attack, we're just having just downtime in general during that time frame, it can be life or death for a patient. And it's where a lot of us, especially the rural folks, that there's one or two of us. Most hospitals in Kansas have one or two IT people on the rural side. Mm-hmm. And it's a 24/7, 365
really
kind of
is.
solution that we're all working through to keep that up.
You guys really,
stressful.
In general, I mean, the burden that is on healthcare IT it's monumental, because it really is life or death, because we are so dependent on the technology in order to render the medical care that the physicians need.
And keeping the physicians, in communication with, we still fax so much stuff. I would love to have faxing leave my life, but it won't happen anytime soon, I don't think. But we're still fighting faxing to different places. It's just
it is the one industry where fax has just stayed.
That and insurance.
Yes. Yeah, you're right. And that's probably why it's still
because we talk to insurance so much, probably.
Right.
But yeah,
that's exactly right.
We'd love to, and then that's where the
pretty secure though. I mean,
HIPAA. It's the cheapest, securest HIPAA thing you can get a hold of for most small businesses. It is so funny that we're getting better and better at talking to hospitals electronically.
Yeah.
We're getting better at using the QHINs and the HIEs to say, hey, I can send you stuff over here. I don't have to send you a fax anymore. But we still get a lot of patient records just faxed, or people want them sent to their other hospital in the hospital. We'll just send them to us a fax. It's the fastest, quickest way to give them to us, and we'll scan them back in. So it's amazing how much we still do of that.
Yeah. Well, and there's not, I mean, part of that has to do with the hacker mentality. They're not really honing their skills on how to breach fax machines. Like they're busy working on AI and other things today where they could do scale, like they could hit 50 hospitals, right?
Not if you're just gonna get my one
individual fax machine they want to compromise. Yeah,
and not worth that one patient's record that's probably got nothing other than other than his
what are they
social
going to
get? Driver's license, a couple things you might want in it.
Exactly, which they could buy from anybody else online. So growing up in rural Kansas, how did you get into IT in general? And you were also involved in law enforcement. So walk us through that. There's some great leadership.
I grew up in a small town south of Topeka, a little bit and I was very lucky to grow up in a town with a nuclear power plant in town. So our town had a very large tax base in the 90s in the east. So the schools were excellent. That's where one thing my parents were both school teachers. So we had a lot of the capital outlay monies to spend on buildings and equipment and that kind of stuff. You couldn't pay teacher salaries with it, which is dumb as a person whose parents were teachers.
Yes.
But you could build a very, very nice ball stadium.
Right.
Or in our school,
there
we
was
built
infrastructure and facilities being built
definitely.
And things like that. Right.
And technology was part of that too. We, Coffee County, where I grew up, had in Burlington, where I was at, we had one of the first fiber networks in the state of Kansas in the 90s. That we could talk to any school in the county over fiber.
That's advanced, actually. That's quite advanced.
I took Spanish over, we call it IDL, Interactive Distance Learning. I took Spanish one year. And our teacher was never in our classroom. He was always in one of the other four schools in the morning. He came to Burlington in the afternoon. So I saw him like the first day of school and never saw him in person until the end of the year. Because he was always just at another school in the morning, and then he'd come to Burlington to do a couple classes in the afternoon. So we were hooked to the libraries in town, and all the schools were hooked by fiber. So it's very kind of interesting to see that kind of technology growing up in that area. And then with that came every school had a technology lab, but the middle school and high school were fairly new when I was there. So a lot of technology modules on everything from PC repair to robotics to video editing, coding, all kinds of stuff. Anything kind of technology, drafting, that kind of stuff. You had options to do that.
This was back in the 90s, so this was actually quite advanced, actually.
Yeah,
for back then.
we were very blessed to have that kind of system in Burlington. And both parents are school teachers, and I give my mom and dad a lot of credit for not. They both have masters in education, and I decided school was not I was not the best student. So school was not my everyday love. So I was talking to our guidance counselor. Hey, what do you thought? I thought about tech school. That might be more your alley. And Burlington, if you were a decent student and did half your stuff you're supposed to, your senior year you had 2 required classes: government English. That's all you had to take.
Yeah.
Then you could take,
And the
5
rest
hours
you
of
could
wood shop.
take is like tech
Yeah.
school
Tech
classes.
school.
Yeah.
So actually, I drove to Emporia, Kansas, only about 45 minutes away. So every morning, me and about 5 other kids got in a school bus, went to Emporia every day. So I took my first year of tech school during high school.
All right.
So I was in tech school every morning from 8 to noon, and we drove back my last 2 hours of government English. Then I computer aided, which works in our technology lab, for another hour every day. So that was my kind of kickoff into tech school. I did 2 years, and then I did that for my whole senior year. I was gone all morning and did that instead of going back to it. I liked it. It was something, I would say the first year of my tech school was a lot of Microsoft Office, and the first semester, which is funny because I already had, Bruns, we had good technology, so I already had 2 years, or at least 2 semesters of Microsoft Office under my belt. So I went to tech school, and they basically said, well, here's your Office 2000, which is when it was, Office 2000 textbook. And I said, well, I've already done all this. And she's like, well, here's how to learn Access. And I'm like, oh, no. So I did a lot of Microsoft Access for about a semester, which is good. A lot of Excel, advanced queries, that kind of stuff, which is cool.
Right.
I'm very good at Excel now.
Yeah, absolutely.
And then the second semester was PC repair and that kind of stuff, which I did enjoy. I did much more PC repair and electronics and that kind of stuff. So then the second year was all Microsoft certifications, and I'm old enough now. I'm a network certifications. So I'm actually a certified network engineer. That's worth about nothing anymore.
Well, I don't know about that. It's still a remarkable skill.
So, well, I've pulled network out of more places. Everywhere I've started for a couple of years, I help remove it.
Yes.
And then I'm also a Microsoft certified system engineer as well in NT4O, which that's how long ago that's been.
Wow.
So it was a really good starting off point for that. Gave me the basics, the hands-on. That was much more. Now I know my learning style, the hands-on, the labs, that kind of stuff was more my learning style, which is great. So that we got out of tech school there, finished that up, went to work for Leavenworth County in Kansas for a couple of years as a IT tech, and then got a friend of mine worked here in Sabetha for a controls integrator here in town, and said, "Hey, you want to move back to a small town?" So that sounds like a good time. So here I am, and through them, I worked as the small town integrator didn't need a whole lot of IT staff. There's about 30 people work there. So we outsourced our IT staff, which at the time was me, to businesses around the community as well. If you needed, the city needed somebody, a couple of
shared service
plants,
model. Yeah.
Kind of thing.
Shared service model. Yeah, that's really good.
So I guess, a day here, a day there. We got enough. I got busy enough. We hired a second person to kind of work with me to do that kind of stuff.
Yeah.
And the hospital became a customer. They said, "Hey, we need this is 2004. We're just kind of starting, when I first started working here at the hospital as a contractor, there was 5 computers here. There's an AS400 sitting on my floor holding my printer up right behind my desk.
Wow.
We still had a mainframe system here for that. And then about 2007, they got enough.
When servers were huge and complicated and there wasn't much you can do to them.
Yep.
Unbelievable.
The AS400 still sitting here on my floor holding my printer up. And then about 2007, they started getting, more. I was spending about half every week here anyway. They got more and more computers. So about 2007, I came over here full time as the IT director.
Unbelievable. That's phenomenal. What? How'd you get involved in law enforcement?
Well, grew up in the Boy Scouts, kind of a scouting program. So that's actually how I got to Sabetha. My friend who worked at the integrator was a friend of mine through Boy Scouts. He's actually a leader of ours.
Great.
Met him years ago, and then my boss at the system integrator said, "Hey, you don't know anybody in Sabetha at all, because I don't. You need to get out and do something." I was working 200 hours a month. I just didn't know anybody. I was a young kid, was working all the time, and so we need to find you a hobby. And so I kind of went through the small town things. Either you can be a volunteer firefighter. That's nothing wrong with that. A paramedic, volunteer paramedic. That seemed like a lot of school I didn't really want to do. And he was a volunteer sheriff's deputy at one point in his younger years. So I got, he's like, "Hey, you ever thought about doing this?" And Maybe. We just did some stuff through Scouts with the law enforcement. I had good friends. I worked with the Leavenworth County guys when I worked over there doing IT for them. My good friend of mine is the undersheriff of the department back home. So I kind of talked to them, said, oh, yeah, you got to do that. It'd be good to get back with your community, kind of give back. So about 2005, I went over there as don't get paid, just volunteer time, right around full-time guys, just doing community activities, doing a lot of community service work,
filing, probably some. Did you do research? Did you do any
help
with investigations, or was it more admin related?
It
probably
was
back
100%.
then, you were
Here's
kids
uniform.
Still.
It's 100%. Here's a uniform. Here's a uniform. Hop on with these guys. Get you certified to shoot this firearm, and then to go help the guys do whatever they need to be done. So I
cool.
As a unpaid volunteer, I was driving around in a cop car, carrying a gun, getting trained on how to do search warrants. A lot of driving around, just backing up full-time guys. Where it's like, hey, small town. We have at that time 5 full-time deputies. So when we had about 6 or 7 as volunteers, that on a Saturday night when I didn't have any kids back then, I'd hop in with him and we'd run around and we'd
do the drive-alongs. Yeah,
do the ride-alongs. Doing a lot of,
I've done those. Yeah,
doing a lot of that and doing a lot of just hey, let's go to the ball. Tonight's baseball game. Let's go walk around the baseball stadium. Or this is the system for the football game. Let's go help out with that. Or a lot of that for a couple years. Playing tackle dummy or dummy for the trainings.
Mm-hmm.
Getting I've been pepper sprayed. I'm not pepper sprayed. Luckily, I've been tased several times. But I've been flashbanged a couple times in my life. Playing bad guy. Would not suggest. So yeah, then about 2007.
Don't go do that on
Kansas,
the weekends. Yeah.
You can only work as a part-time employee at the sheriff's office as a deputy. You can only work 200 hours a year. You have to go through a 2-week part-time academy. So I had to go down to Hutchinson area in Kansas and take a 2-week certification class to get so I could work by myself and have a normal kind of salary at the sheriff's office.
Oh yeah.
That was in 2007, so I've been doing that since I've been at sheriff's office now for over 20 years, and I've been a full paid employee for probably 19 of that now, 17 of that now.
That's phenomenal.
A lot of, and that, of course, then as part of that, they found out that I was a IT person. So hey, they were just getting computerized records at that point in 2005. Yep. So I got.
So for the listeners, CJIS, and I forgot what the CJIS actually stands
Criminal
for.
Justice Information Systems.
Correct.
Just like EPHI, it's CGI. So it's very similar.
It's really when you're working in IT and you have access to these investigative reports and confidential information, you are taking an oath and you're trained, and then you take an oath that says like, I will, under penalties of perjury or under penalties of going to jail myself, I vow not to release this stuff and to keep it confidential.
It's just kind of like HIPAA just for cops.
Right. Yep.
We keep stuff in confidentiality. We don't send. It's kind of shockingly similar on how we can't send stuff unencrypted across non-secure lines. We can't. We have to have our data, secure where we store it. We have to have certain people who can only have access to things. We have to do physical security of like, hey, you have to have your server rooms locked and your dispatching areas secure.
Yeah, we have a lot of CJIS engineers on our staff, and
it's a good pivot of a lot of healthcare stuff. So it's been a good fix of both sides. We're just rolled out multi-factor to the desktop level over there as required by the state here very soon.
Good.
So we just kind of rolled that out here in the last month as we're working through that.
That's phenomenal. Hey, so what, any leadership lessons you've gathered up from working in law enforcement and healthcare? Like, what have you seen, or what are some of the traits that you find that really demonstrate excellent leadership?
So you got to be willing to. You can't have that my way or the highway kind of mentality. It's very easy to say I am the expert in this, and you need to do what I say. And that works in both kind of ways. You've got to you got to be able to communicate what you need, articulate why you need it, and also just realize that not everybody's going to want to do things your way. If you can, find that good common ground, say, hey, I know you want this. I want this. Can we find a way that makes us both at least reasonably happy here? And there are lines like this is legal requirement. We cannot do this.
Right. We have
but there's
to
a lot
do
of that
this
gray area. A lot of that gray area. It's like, hey, or what can I do today to make us better than we were yesterday? And what can we do tomorrow to make better than we were today? So kind of build on that. Both locations, build on that as, hey, as long as we're moving upward, we're making the right direction. So don't get such in the slump where it's like, hey, I want to do this. They said no. What do I do? So we got to find the best thing we can to get us by where we're at today. So.
And communication is really key there, right? Like when leaders explain the reasoning and the context for why this is the betterment, like we're all part of the team. This is better for the organization because of this. Then at least you understand the context. Like
I had a
my frustration. Yeah, my frustration with leadership sometimes is when you get a directive and there's no context and you're like, I'll do it. Yeah, that's fine. I just don't understand why. But then as soon as they explain why, as soon as they explain why, you're like, makes total sense. And then you're able to explain it to your teammates. And then, you know what I mean? And it really helps understand the context.
I've asked people, give me your, I've had some bosses before. It's like, give me the problem and I'll tell you what I think is a solution. Don't give me solutions to what you think the problem is. Because how you look at stuff and I look at stuff are two very different things. So I look at things as an IT person.
Right.
Instead of, as you say, hey, I want you to put this thing in, like, what? That might fix that, but it's not going to fix this, or this. Put this in and fix all these things. And this is just barely either more expensive or sometimes even cheaper than one you wanted to put in on the long run because of the amount of time it takes to put it in and the amount of effort to put it in. And nothing's more frustrating to an IT person than all this. I'll do all this work, and then no one will use it because I got told to put this thing in and nobody really wanted. But hey, somebody saw something somewhere saying, hey, that's the next best thing. We need to get that put in and we have to have this thing. Like, okay, I put it in, like, oh, none of us wanted that.
Right.
I don't know why we're doing this because it doesn't work right. And like, well, I was just told to put it in. So
yeah,
I got
exactly.
100 hours to put this in.
And the
now
context, etc. Yeah. And that is so common. There's so many initiatives that get brought up from a grant or from somebody seeing something that's cool, which brings me, before we wrap up, I want to ask you about AI. So AI is being rolled out in a lot of healthcare organizations.
Ours included.
Yeah. I mean, how are you guys implementing AI? I've seen it used where it's being used very similar to, let's say, Microsoft Teams, which it'll summarize the meeting and the notes and give you the highlights, the next steps, the actions, who's responsible for what. It's good to have that all done for you. That way you don't have to rely on my handwritten chicken scratch versus yours, etc. But in the healthcare space, it seems like they're rolling it out for summarizing medical records or charting and things like that, because that could really save time.
So we have rolled out, and we're about to kind of roll out a second phase of it, I think, now, because it's worked out fairly well. Everything's still a work in progress, even AI stuff. It's amazing, when I was at HIMSS in 19, AI was just kind of a trickle of a discussion. And in 2024, when I was there in Orlando, you couldn't walk 2 feet without sitting something AI. And last year, It was a whole pavilion based on AI. So I think we're rolling out Weave's Oracle Health for our records. So they have some patient. You set the phone down, you open the app up, set it down, and you have your meeting with your doctor, your appointment doctor, and it transcribes the discussion you're having. That's why the first thing we're kind of working through on this is getting that kind of set up. And it's worked well. I think it's still a work in progress. We're having the doctors kind of keep notes on it for now, just because of it is. I wouldn't say it's not accurate. It's just not doing exactly what they want. It's saying what they're saying. But there's a little bit of interpretation to it. It's not making any kind of clinical decisions for them. It's not making any kind of ordering of drugs.
Is it capturing the medical terms? Yeah, is it capturing the medical terms? Okay,
yeah,
good.
It does do a pretty decent job of finding. It's not perfect, and that's why you have to. It says very much in our documentation. You have to read this thing and make sure because we're using it no different than we used Dragon.
Right.
because
and Dragon's been around for years.
And we used it for a long time, and we had some really interesting discussions with doctors where we had one doctor that didn't like the dead man switch. You had to press and hold it, so he wanted the on off switch, which we did for him until he realized he was setting it down and not turning it off, and we were getting discussion about baseball and all kinds of stuff in the background into this patient's chart. But they realized it 10 minutes later, and there's this 10 pages of discussion that he has to go back and delete back out of his note before he saves it. So it does a pretty good job. The future, the things they're showing as an option now are kind of amazing. The stuff they're demoing some of that. We never want to take the doctor out of the decision there, because I don't want a computer deciding my mental health record for me. I want this doctor I'm seeing to decide that for me.
But there's a lot of research that it can do quickly. Yep. And correlate.
It can look back through my chart.
Right.
And it's like, say, hey, and the new version of some of the EHR stuff we looked at is you would talk, hey, can you show me Shawn's last 5 labs? And are just, here you go. And so him click through and do a bunch of looking and try and remember, okay, your lab was this on this day, and this on this day, was down to here. And you say, hey, what was the corresponding drop? Was there anything else corresponding with that drop in this lab? Yes, he was on this medication. That results in this. The features that we're hopefully going to get one of these days will save a lot of time for the providers. That's what a lot of this is the doctors have used this system. Say it's not, the charting is still charting, but they're not staying there late.
It's still a task.
Typing.
It's still a time.
Yeah, it's still a task. They're still definitely involved in it, but they're not sitting at the office at 6:30 at night typing up notes or dictating notes, because when they get done, they sit down, they can review what's been typed for them, correct it, make any additions they want to add to it, and that's done. So they're not spending 20 minutes voice dictating to this thing that's basically doing the exact same thing that the system did on its own, and just saying that kind of keyboard time.
Yeah, makes perfect sense. That's excellent. And then you just figure out where the servers are, or where they're keeping the data, right? Just to make sure that it's compliant. But I'm sure any organization that is offering something in AI to hospitals has worked through that before they go to market, one would assume.
Yeah, you'd hope. I know with ours, there's supposedly nothing. I'll say supposedly because I have not sit and verified this, but they tell us there's nothing stored on the local device. It's all stored in their cloud. There's nothing. So if someone steals the doctor's iPhone, they're not getting any of that data off of it because it's supposedly not there at all.
Right.
So which sounds awesome.
So that's fantastic. That's really good. Yeah.
But even that, we're looking at the same message for the nurses, where the nurses can do some of these things. We're getting the nurses where they can have a computer in the room and voice dictate what they're doing. Hey, I'm wrapping this bandage. I'm on the left arm at this time. This looks good. I'm doing this, and it will type all that for them. So they're not. That's a lot of nursing documentation is just reviewing what you did. If you can voice talk yourself through that as you're doing it, and it'll type up your notes for you, and you say, oh, yep, I gave this med at this time. I verified it with the barcode on the med. I rewrapped the arm. Looked good. Wasn't any issues.
Well, one would think it would really reduce mistakes. It would reduce errors. So that will render itself or wind up
when you take one step out of the documentation process. You'd hope it would just taking memory out of things, try to remember what you did. Because the problem is our nurses get busy, and then it's 4 hours later. I can finally sit down and chart some of this stuff. And a big ER trauma where they're all hands on deck and they're not documenting stuff. They are writing things on their arms. They're pulling stickers off drugs and things and stick them on their shirts. They can chart it later as they're trying to get this patient coded. If they can just be yelling that stuff out to the system and have it document what they're doing, it's great. So there's some major patient safety and patient staff safety.
I wonder what the next evolution is going to be. Where do you think it's going? Trying to look into the future. I mean, are we just going to have videotape of everything? I wasn't at the hospital that day. We're like, we have you on video doing it, but then you have deep fakes. As an
with law enforcement, same way. We all carry body cameras now. When I first started, that was a big imagination. You never thought we'd all be carrying cameras on us.
But thank God you do, because there's so many. I don't want to say lies, but there's so much misconception to what happened, and then you're able to look at the tape and be like, "Oh, that's exactly what happened. This is what happened."
We've had car cameras for 20 years.
Oh yeah.
And that's always never been a problem. I didn't ever mind the car camera. I don't mind the body camera either. Mm-hmm. I've always said it's never hurt me. It's always only helped me. When I got to go back and someone says, "Hey, argument about something," well, we can just watch the video. It's not a secret. It happened.
Right.
It's available if you want to see it. We can pull it up, and it just keeps all of us honest, which is not a problem for us. But it turns this she said, he said, or whatever things into facts, which is nice to test at the back of what we know.
That's phenomenal. So every industry has associations, and healthcare has HIMSS, and you're involved in the GPHA as well. What are some of the key benefits that HIMSS offers as an organization to rural healthcare?
So HIMSS, so we're part of the Kansas chapter. Kansas is kind of different because we have 2 chapters in our state.
Correct. One right around Kansas City, and then one for the rest of the state, right?
The Heart of America, or the Greater Kansas City, used to Heart of America, Greater Kansas City chapter is the Kansas City and a good chunk of Missouri, actually, kind of around the KC metro area, and we're everybody else. So we're almost all rural. Topeka is in ours, Wichita is in ours, Salina, Hayes, Med. But the majority of us, Kansas and Iowa like to play the game of back and forth. Who has the most hospitals and critical access hospitals in the nation? Depends on who closes the least amount of hospitals. I think Iowa may be ahead of us right now. But we're going back and forth on that. Some of the network, I started in 2008 when I first kind of got started as IT director here. They said, "Hey, there's this group of IT people. You got to get to know them. They meet every once in a while." So I got into about 2008 when I first started at Kansas HIMSS, just as a member, and just got to meet other IT directors throughout the state. The networking's great. Our big conference we had back in April in Wichita, that we had a big discussion on cybersecurity, AI, the security kind of things going on right now with some of the major changes in the Fed level. Trying to get that cooperation, a lot of education. HIMSS has some certifications you can get that are very well known in the healthcare industry as great qualifiers. So it's been I got involved with the board about 2013, I think. I'm looking back, as just kind of helping with sponsorships and events, and then I kind of went through the vice president cycle. I think I'm currently, for another 2 weeks, I'm still the secretary until our officer elections are going on right now. So I'll be stepping back just into my events role starting in July.
That's great. Well, I mean, to me, there's so much core knowledge that gets exchanged from those engagements, because you're able to see, hey, we were thinking of trying this application, rolling out, and you can talk to 2 other hospitals that tried to roll it out and it was terrible. You're like, thank you for that, because now I'm not going to. We do I'm not going to die.
A lot of networking is like, hey, right? We're looking for a new PAC system. Like, hey, who's this? Oh, it was awful. We really liked ours, or we had a couple of people like, we're looking at something different, but after feedback, we're gonna keep what we got. Everybody else seems to like what we got. Apparently, it's the best thing around. And you'll try something that they haven't tried yet, so you're able to relay that. And I just think that overall awareness and knowledge from the collaboration is so important, and the education and stuff. Yeah, and like, so we were in we had some really good. There's about 300 members strong in Kansas. Not a lot of those are vendors that join it, which we're happy to have anybody join. So we're a smaller chapter on our level, but we have about 80 to 100 people that are fairly active and want to get involved and want to do things and come to meetings. The networking is awesome. So, Dave was at our meeting back in April, and we had around 80 people, about 90 some people.
I loved it.
Just good collaboration, good discussions, lots of good discussions. You got to see me in an alien costume running around at a conference.
I love an event that, even though we were presenting at it, like, I learned so much. Like, I just coming away from the event and talking to people that are in the trenches, seeing at other people that are helping other organizations in other states. Like, it is just so interesting. Like,
and a lot of it is just knowing that you're not alone in some of this, especially in rural Kansas work. Like, you're for till about 3 or 4 years ago, I was the only IT person here, so it was me. Yeah. So if I knowing like, hey, who can I call and talk about this thing that will understand exactly what I'm talking about, and because no one else at the hospital here until I hired my other guy working for me,
Yeah.
would understand. So it's like, I
exactly
need to
right.
bounce my ideas. I need to vent my frustrations about something IT related. No one else here is they'll shake their head and nod and give me the,
Yeah, but then no one's going to understand it unless they've been in the
I
trenches.
I'll call Alicia or Scott or one of the other board members and say, hey, what do you think about this? And we do a lot of projects, we're part of the Great Plains group too, where we do a lot of stuff together, like our antivirus we try to buy together as a larger group. We're looking at some office training, like, hey, let's do Intune together and learn how to do it together.
Right. Yeah, it's good.
And same for HIMSS, we try to do education. We do Cyber Month every year where we do a month-long cybersecurity awareness kind of thing all October every year. And because we always say that when when one of us is smarter, we all are a little stronger, because it's
right.
Because when one hospital gets hit, and one hospital in Kansas gets hit, it affects a lot of us.
Yeah,
It
absolutely.
affects our HIE. If a hospital, I'm very lucky to have hospitals kind of close by me. I'm on the side of the state with trees and people on the east side.
Right.
Where I can go to a hospital within half an hour, 15 minutes, all about every direction. Out west, if one of those hospitals gets hit, the neighboring hospital is going to get it.
It's ours. Yeah.
And some of these, we've had one hospital in our network that they didn't get cyber attacked, but one they worked with did, and it came over to them through some VPN tunnels. They had legacy stuff that they were still using.
Yeah.
Yeah, and it got into their system. That one hospital got hit, and they had some old legacy VPNs set up for some old records
and they got in from there,
and it came across the VPN and got into them. So
unbelievable.
And we are such a good collaborator, especially here in Northeast Kansas. We collaborate very well. We work very well with a couple local hospitals that we share staff. We got a surgeon we share between three of us.
Yeah, that's great.
One hospital has a dermatology clinic that they own that we use, and we have another person down that is credentialing for us. All three of us use together, so we're very collaborative. It's kind of funny. We talk to different people. I think you guys need to stop fighting. All hospitals, we're very close. We're within a half hour each other. You guys need to stop fighting with each other and start working together. It's like we do all the time.
Yeah, all the time.
I could drive over to their hospital in half an hour and walk into their IT guy's room and say hi, and we just talk breeze for an hour, no problem. It's if I got a problem with sending them data, I got a cell phone, call them up. Hey man, I can't fax you. What's going on? That kind of
That's
stuff.
Amazing.
So we're very collaborative, and in Kansas, there's very few hospitals that are kind of because we can't be like that in Kansas. We're all too
right.
We're too nice, but it's also we're just too rural. It doesn't do us any good to have that silo. It's like, hey, I'm going to be my own thing. I'm going to do my own stuff. I don't want nobody else to talk to me. I want to do my own way. It just doesn't work.
No, exactly. Well, Shawn, thank you so much for your time, my friend. I really appreciate it.
Hey, thank you, sir.
We will have links to the hospital in the show notes and links to you and your LinkedIn. If anybody wants to connect with Shawn, you always have good content, good insight. You're definitely one of the subject matter
HIMSS is always
experts.
good research for anybody, or HIMSS in general. There's over 56 chapters of HIMSS around the world, mostly in the United States, a couple in India.
Yep.
But I think if you ever want to get involved in healthcare IT, HIMSS is a good place to start. There's a lot of local chapters, a lot of cool stuff.
Very good. Well, thank you so much, sir. I really appreciate it. And
hey, have a good afternoon.
You too, my friend.